That's it. Assalamu alaikum. Respected participants, can you hear me?
Walaikum assalam. Yes, sir.
Okay. Let the chair and co-chair join the session and we will start then. वालेकुम अस्सलाम से डॉक्टर हाशिम बात कर रहा हूँ. Assalamu alaikum. Dr. Kashif as co-chair has joined. We will wait for the chair to join the session and we will resume the session then. let me call to the chair again. He just said that he is going to join the session. Meanwhile, to all the participants, if anyone from you is willing to recite the Holy Quran, if anyone, otherwise I will recite the Holy Quran in the beginning. If anyone want to volunteer, is more than welcome. Now the chair and the co-chair and the participants have joined the session. So if all the participants are available, then should we start the session? Dr. Kramatullah and Dr. Kashif. Sir, can you hear me?
Please go ahead.
Okay, sir. First of all, I would like to Bismillahirrahmanirrahim, and I would like to welcome all the participants in this today's session. I will start today's session with the recitation of Holy Quran. A'udhu billahi minash shaitanir rajim. Bismillahirrahmanirrahim. Qul huwallahu ahad. Allahu samad. Lam yalid wa lam yulad. Wa lam yakul lahu kufuwan ahad. Sadaqallahul azim. Assalamu alaikum and a very good morning to respected excellencies, distinguished guests, and all the participants. On fourth day of third International Conference of Rehabilitation Sciences at fourth oral presentation, I am Dr. Muhammad Hashim, currently serving as Assistant Professor at Riphah College of Rehabilitation and Allied Health Sciences. And it's my honor for being a moderator of this oral presentation session with special theme, Sports Physical Therapy. This session will be chaired by Professor Dr. Keramatullah and co-chaired by Dr. Kashif. We feel honored to have these personalities with us, and I would like to introduce the chairperson of this session, Professor Dr. Keramatullah. He has over 19 years of experience in physiotherapy teaching and research. Dr. Keramatullah graduated from the University of Karachi with a bachelor's degree in physiotherapy with gold medal and completed his MSc from NUI Galway. Currently, he has enrolled in PhD at ISRA University, Islamabad. He has previously served as a senior physiotherapist for almost 6.5 years at Waterford Regional Hospital at St. Patrick Hospital, Ireland. Currently, he is working as a principal, associate professor, clinical director at Helping Hands Institute of Rehabilitation Sciences. He has the honor of writing 13 national publications and completing 16 research projects. He specializes in working with in and outpatients of acute illnesses, elderly patients, and respiratory care and sports patients. And co-chair of this session is Dr. Muhammad Kashif. He has over 15 years of extensive experience of clinics and academics in physical rehabilitation and is a serving member of Pakistan Physiotherapy Association. Dr. Kashif has received his MS in physiotherapy from Anglia Ruskin University, Cambridge, UK. He has been working with Handicap International, French-based international NGO, Muzaffarabad, Azad Jammu Kashmir as a technical officer. Dr. Kashif has a strong academic and a research background with numerous national and international research publications. He is now serving as Principal Associate Professor at Riphah College of Rehabilitation Sciences, Faisalabad. Now, I would like to ask respected chairperson to kindly allow us to proceed the session of oral presentations with the theme Sports Physical Therapy.
Please proceed.
Thank you, sir. We have few live sessions and few recorded sessions, and the first participant who is going to present his oral presentation is Dr. Irum Nosheen, and her title is Level of Fitness and Frequency of Injuries Among Different Sports Players. Let me start her speech.
Bismillahirrahmanirrahim. Assalamu alaikum. I am Irum Nosheen and the topic of my research is level of fitness and frequency of injuries among different sports players.
Are you all able to see my screen?
I can see it. I don't know about the audience.
Let me share it again.
I think their mic is mute, so you will not hear from them.
Then I said, I'm just saying that, are you able to see my screen?
Yes, I can see it. I
Okay,
can
sir.
see it. I don't
Okay, sir.
know about the rest of them.
Okay, sir.
Hashim, I can also see it. Is it
Okay, sir.
live one or recorded one?
So it is recorded one, but the participant is here for the question answer session.
This research is conducted by Irum Nosheen, Sadia Batul Muhammad Latif, Anar Ahat and Dr. Aruba Saeed. Introduction. Physical fitness, when defined, is characterized as a state of being able to accomplish activities with vigor as well as indicating low risk of developing hypokinetic diseases that are linked to physical inactivity through certain traits and capabilities. The injuries in sports range from mild to severe. Whatever the injury may be, it always interferes with the physical performance of the player and affects the level of fitness of an athlete from minor to significant level. Individuals with higher physical fitness levels are at an advantage as compared to those with a sedentary lifestyle and low physical fitness levels. One of the many beneficial effects of a higher physical fitness include positive impacts on physical and psychological well-being. Players are not only required to have physical fitness, but they are also required to exhibit under pressure excellent tactical, reactive, and anticipatory capacities of certain match deciding points, all of that while coping with the fatigue caused by the physical demands of a sport. Literature review. Renovotz et al. In 2018 conducted a research under the title Resistance Training in Young, Benefits and Characteristics. This study concluded that due to inactivity among young population, there is severe decline in muscular fitness, and the problem can be overcome through resistance training exercises. Ulbricht et al. In 2016 conducted a research under the title Impact of Fitness Characteristics on Tennis Performance in Elite Junior Tennis Players. The study showed that certain physical characteristics need to be included in the area of physical training of the young players. Dube et al. In 2018 conducted a study under the title Musculoskeletal Injuries Among Adolescent Cricketers. This research included 240 subjects, and it concluded that knees, lower back, and shoulder were found to be most vulnerable regions of the body for injuries. Occurrence of injury was found to be about 35%. Uruj et al. In 2016 conducted a research under the title Common Injuries in Field Hockey. The research determined that athletes experience injuries which affect their performance, so protective measures should be taken to prevent injuries in future. Significance of the study. Study conducted will contribute to the research literature on athletic population in our society. Players will come to know about the level of fitness and frequency of injuries in different sports so that they use different methods to improve their fitness and to prevent injuries. Research gap. There are limited studies conducted in Pakistan which encompass different games in one study for finding the frequency of injuries in players. Limited literature is available to assess the physical fitness of players of different games. Here are the objectives of the study: to determine the frequency of injuries among different athletes, to determine most susceptible area to injury among different athletes, to determine the level of fitness among different athletes. Methodology. Study design was cross-sectional study. Sample size was calculated by OpenEpi tool and was estimated to be 318 with 95% confidence interval, 80% power assuming population size of 20,000. Sampling technique. Non-probability purposive sampling technique was used. Duration of study was 6 months, starting from July 2019 to December 2019. Study settings were Islamabad Sports Clubs and Rawalpindi Sports Clubs. Sample selection. Inclusion criteria. Football players, cricketers, hockey players, and badminton players participating in games greater than 3 months, participated in game more than 3 days a week, age greater than 18 years, willing to participate in this study. Exclusion criteria. Inability to physically perform any of the required assessments, any neurological or musculoskeletal deformity, a player undergone any surgery in past 1 year, player experienced any injury during any other event except match and training session. Data collection procedure. The semi-structured questionnaire was given to the athlete and consent was taken. Analysis was done by using flexibility, balance, coordination, agility, and strength tests to check level of fitness of all the players. All the tests were performed in the following order according to NCSA guidelines. First of all, agility test was performed, followed by flexibility test, balance test, coordination test, and strength tests. Data was analyzed through SPSS version 21. Agility was assessed through agility t-test. For flexibility, sit and reach test and trunk rotation test was used. For balance, standing stock blind test was used. For coordination, alternate hand wall toss test was used. And for strength test, vertical jump and push-up test were used. Results. The mean standard deviation for the age of participants was 26.22 plus minus 6.47. The mean and standard deviation for the BMI of the participants were 22.02 plus minus 3.12. The mean and standard deviation for warm-up time was 19.50 plus minus 10.11. The mean and standard deviation for the hours of sleep was 7.47 plus minus 1.30. The mean and standard deviation for the duration of training in hours was 2.90 plus minus 1.49. The mean and standard deviation for the water intake in terms of number of glasses was 16.80 plus minus 7.06. Type of game. 27.50% cricketers participated in the study, 23.30% football players participated in this study, 18% hockey players participated in this study, and 31.10% badminton players participated in this study. Playing position. Players were playing at different playing positions according to the type of game. All-rounders of cricket were 6.20%, wicket-keeper 3.60%, batsman 9.50%, bowler 7.90%. Forward players of hockey and football were 5.20%, defenders of hockey and football were 10.50%, players of hockey and football playing at back were 9.20%, players of hockey and football playing as midfielders were 7.20%, strikers 5.60%, goalkeeper 5.60%, and the players playing at no specific position were 29.50%, and these were the badminton players. Frequency of injury. 58% players reported an injury, while 42% players did not report any injury during the match or the training session. Out of that 58%, 42% reported acute injuries and 16.10% reported an overuse injury. Players of different games reported injuries at different sites. The most commonly injured area was found to be ankle and foot, that was 13.80%, followed by the knee 11.10%. Injury and playing position. Frequency of injury was also related to the playing position of different games. All-rounders of the cricket reported more injuries, that is 73.60%, followed by the midfielders and goalkeepers of hockey and football, that was 72.70% and 70.50% respectively. Assessment of level of fitness in different sports. Agility was assessed through agility t-test, and here are the scores of agility t-test. According to this table, the agility of cricket, football and hockey players was almost same, lying in the excellent category, while most of the badminton players lie in good category. Flexibility was assessed through sit and reach test and trunk rotation test. According to the results of sit and reach test, flexibility of cricket, football, hockey and badminton players were found to be in super category, but hockey players' score suggests more flexibility as compared to the players of other three games, which were 87.3%. Trunk rotation test. According to the scores of trunk rotation test, players of all the games lie in very good category, but again the flexibility of hockey players was found to be greater than the others. Balance test. Balance was assessed through standing stock test blind, and it was found that the players of all four games lie in poor category. Coordination test. Alternate hand while toss test was used, and the scores in this table suggest that cricketers have excellent coordination as compared to the players of other three games who lie in good category according to the scores of coordination test. Strength test. Vertical jump test and push-up test were used to analyze the strength. According to the scores of vertical jump test, all the players lie at equal level, that is below average, but the vertical jump score of football players was higher, that is 77.5% as compared to the players of other games. Push-up test score suggests that all the players lie at equal level, that is good category, but the score of cricketers, that is 71.4%, was found to be higher as compared to others. Independent t-test was applied. The results of trunk rotation test and agility t-test was affected by the injury of the player, with a significant p-value. One-way ANOVA was applied to analyze the level of fitness of players of different games, and the value of vertical jump test for badminton players was found to be significant with a p-value of 0.003 as compared to other games. The graphical representation is shown here. Discussion. According to this study, frequency of sports injuries in this study was found to be 58%, while a study conducted by Dankner or et al. In 2001 in Israel reported 56.1% injury rates. A study conducted by Stevenson MR et al. In 2000 in Western Australia reported an injury rate of 51%. The injury rate reported in a study conducted in Switzerland by McCord PA et al. In 2001 found injury rate reported was 32.1%. Another study reported rate of injuries in players was 49.2%, and this study was conducted by Helen A. et al. In 2014. According to our study, the all-rounder of cricket were more prone to injury at about 73.6%. A study was conducted in 2012 by Dillon MS et al. On nature and incidence of upper limb injuries in professional cricket players, and it suggested that all-rounders experienced more upper limb injuries. According to this study, ankle, foot, and knee were more common sites of injuries among athletes. The evidence suggests that thigh 23%, knee 17%, and ankle 17% are the most commonly injured sites of the body of athletes. This research was conducted by Giza et al. In 2005. In my study, the performance of 55.1% players was affected due to injury. A study was conducted in 2008 by O'Neill DF et al., and it suggests that injury affects the level of performance of a player. Vertical jump was found to be highest in badminton players as compared to other players of the games included in my study. A study conducted on badminton players concluded that vertical jumping improved the performance of badminton player, and this study was conducted by Jaitner T et al. In 2007. Conclusion. Our study concluded that the average level of fitness in all players was good. Balance was the one component of level of fitness which was in poor category for players of the four games. The athletic population were more prone to injury. The most commonly injured areas among athletes were ankle and foot, followed by knee among players of cricket, football, hockey, and badminton. Recommendations. Objective tools must be used for the assessment of level of physical fitness of players. More researches must be conducted for the assessment of balance of athletes. Comparative study of frequency of injury and level of fitness among males and female athletes should be conducted. Limitations. The distribution of players was not equal in all four games. This study included only the male players. The results of the study cannot be generalized as it was conducted in Islamabad and Rawalpindi. Here are the references. Thank you.
Thank you very much, Dr. Irum Nosheen, for presenting your paper. Now we will proceed to the next paper. It's a recorded session. Dr. Komal Ahmad will present frequency of functional limitation among football players suffering from ankle sprain.
In the name of Allah, the most beneficial and merciful. Let me briefly introduce myself. My name is Dr. Komal Ahmad. I have done my graduation in Doctor of Physical Therapy and post-graduation in Orthopedic Manual Physical Therapy from Riphah International University. Currently, I'm working as lecturer at University of South Asia. I'm delighted to be part of 3rd International Conference on Rehabilitation Sciences. First of all, I would like to thank Riphah International University for providing online platform during this pandemic. I would like to take this opportunity to talk about my research paper, that is frequency of foot and ankle disability among football players suffering from ankle sprain at club level Lahore. Let me give you a quick introduction to my co-researcher, that is Dr. Khatija Liaquat. Here I would like to give you some background information about my topic. Football is undoubtedly the most admired game played globally. Approximately 270 million people are playing football according to a recent calculation by International Federation of Football Association, withholding the risk of injuries for players both at professional and recreational level among all age groups. Let me elaborate that while many other studies of different countries have reported the rate of injuries for particular body regions or for individual injuries in football, up till my knowledge, no published information exists that find the frequency of ankle injuries among football at club level and to assess their functional limitation related to foot and ankle conditions. I would like to move towards the literature. Trots11 in 2017 found that 15 to 19 years old footballers for the Norwegian national team have many overuse injuries. Ankle sprain was the most commonest reported acute injury. Muhammad Al-Malkani in 2017 found one-third of students had ankle injury during their school time being played as footballers. The prevalence of ankle injuries of the included participant at the time of study, last 6 months and 12 months were 14, 31.7 and 34.7% respectively. Meanwhile, Amy Elizabeth in 2016 examined risk factor associated with injuries related to ankle in football players at a Division 1 university. The total ankle injuries were 1.7 per thousand athletes exposed. Turning our attention now towards the methodology, cross-sectional study design was used and data was collected from some major football clubs of Lahore, including Real Lahore, Bata FC, Raiders, etc. Non-randomized convenient sampling technique was used. Players between 15 to 25 years old who had grade 1 and grade 2 sprain with positive stress tests were included in the study. Average playing time was 90 minutes per day, and those who had grade 3 or any other red flag sign were excluded from the study. Lastly, data was analyzed through SPSS to get the frequency, bar charts, and histograms. I would like to draw your attention to results. The participants were assessed on the basis of inclusion and exclusion criteria. Mild to moderate difficulty of pain was seen during routine activities. In sports sections, the frequency of disability and pain level was comparatively more. This explained the principle of specificity. Results of this study show more involvedness in sports related injuries as compared to ADLs among football players. Percentage of pain show marked increase in journal level of pain during normal activities. Summary of the discussion show that the ankles sprained players of football were experiencing moderate level of difficulty pain in activities of daily life, household tasks and sports activities. There should be awareness and education of restriction activities. First of all, in the players who sprain ankle, and secondly, the ergonomic ways should be devised and advised to players for the better recovery and prevention. In conclusion, let me sum up my main points that comprehensively moderate the frequency of football players with sprained ankles was experiencing foot and ankle disability. Sports activity found to be more effective as compared to those of activities of daily living. They were mild during normal activities and generally, while no more obvious pain was found during rest and in the morning. Recommendations include additional studies to reveal the role of different orthokinematics following ankle sprain. Further investigations should be studied to find the mechanism of injury, contact versus non contact, type and position of play, ground versus artificial turf that lead to injuries. Longitudinal studies should be conducted to see the injury rate in a bigger picture. This research was limited to only find the frequency of functional disability due to ankle sprain. Researchers are needed to analyze different etiology, recurrence, and strategies to improve football game at club level. That brings me to the end of my presentation. Thank you all for your kind attention.
Thank you very much, Dr. Komal Ahmad, for presenting your paper. Now, Dr. Rikza Riaz will present a recorded session on frequency of kinesiophobia and hair-related quality of life among athletes with chronic ankle instability.
Bismillahirrahmanirrahim. Assalamu alaikum. I am Dr. Rikza Riaz and I am delighted to be a part of third International Conference on Rehabilitation Sciences. First of all, I would like to thank Riphah International University for providing such platform. I would like to take this opportunity to talk about my research paper, which is Prevalence of Kinesiophobia and Health-Related Quality of Life Among Athletes with Chronic Ankle Instability. As we know, people all around the world indulge in physical activity for personal and health-related interests, including fitness, which exposes the ankle to multiple conditions, which can be a cause of injury. And roughly one half of ankle strains occur during athletic activities. Ankle being the second most injured joint accounts for 15% of sports injuries. Kinesiophobia, which is fear of movement and re-injury, is an important determinant in any chronic pain. This fear can lead to disability and disuse. The results of patient-reported outcome instruments which analyze ankle function, individual health, and fear of re-injury have shown that rate of health-related quality of life impairments are higher in people having chronic ankle instability than those who do not have chronic ankle instability. Let's move to the literature review. Many researchers have focused on ankle sprain and instability. One of those researches was conducted in Australia by Hiller and others in 2012. In that study, it was reported that 60% people had suffered from ankle injury. 45% were those who had a history of ankle injury, but they did not observe any chronic issues such as giving away of ankle. And 24% people had chronic ankle injury, which is characterized by feelings of giving away and repetitive ankle sprains. There is a definite effect of ankle injury or sprain on individuals' health. In a research conducted in 2011 by Brent et al., the effect of ankle sprain on health-related quality of life was examined. This cross-sectional study concluded that people who had functional ankle injury had lower health-related quality of life as well as more functional limitations as compared to uninjured individuals. It was clearly shown that ankle impairments reduce overall health-related quality of life. It is known that ankle sprains increase injury-related fear in athletes. In 2017, Megan et al. Conducted a cross-sectional study to determine the difference between scores of fear avoidance belief questionnaire among college athletes with single ankle sprain, with recurrent ankle sprains, and healthy control. This study showed that ankle sprains increase injury-related fear in general, but athletes with a history of recurrent ankle sprain showed increased level of fear on the fear avoidance belief questionnaire as compared to athletes with single ankle sprain and healthy controls. Moving towards the methodology. It was a cross-sectional study. Convenient sampling technique was used and the sample size was 296 male athletes. Data was collected from different sports clubs in Lahore. Three questionnaires were used, which were Tampa scale for kinesiophobia, foot and ankle ability measure, and disablement in physically active. Turning to the results. This table shows the statistic of 296 participants regarding age, height, and weight. This shows the division of athletes. 42% of my participants were cricketers, 36.49% were footballers, 8.78% were rugby players, and 11.82% were runners. This figure shows the degree of kinesiophobia according to Tampa scale of kinesiophobia score in different types of games. It shows that highest percentage of severe kinesiophobia was found in footballers, which was almost 51%, and the lowest was in rugby players, which was around 7%. This table shows the score of foot and ankle ability measure scale, which was used to assess physical function of participants with chronic ankle instability. This figure shows the degree of disablement according to the disablement in physically active scale, which shows that severe disablement was shown by 50% of the footballers, 31 cricketers showed severe disablement, whereas only 7% of rugby players and runners exhibited severe disablement. In 2011, researchers Brent et al. Conducted a cross-sectional study which showed the effect of ankle sprain on health of the individual. In that study, participants with ankle injury demonstrated more functional limitation as compared to individuals with no past ankle injury. The current study also concluded that regardless of type of game, athletes with chronic ankle instability had impaired level of health. In the current study, it was analyzed that a large number of athletes displayed fear of re-injury after chronic ankle instability. Another researcher, Megan et al., in 2017 conducted a cross-sectional study using fear avoidance belief questionnaire among college athletes with history of only one ankle sprain, with repeated ankle sprains in the past, and healthy individuals. It was formulated that athletes with history of recurrent ankle sprains had increased level of fear of re-injury in fear avoidance belief questionnaire as compared to the ones with single ankle sprain history and healthy individual. Moving to the conclusion. From the study, it is concluded that severe disablement and high fear of re-injury was present in athletes with chronic ankle instability, and cricketers and footballers were more affected than rugby players and runners. Proper rehab and training after ankle injury must be organized in order to minimize the level of disablement and fear of re-injury among athletes. Recommendations include that experimental studies should be conducted with proper follow-up, and to get more accurate and precise results, targeted population of athletes should be recruited in the study. This brings me to the end of my presentation. Thank you for your kind attention. Jazakallah.
Thank you very much, Dr. Rikza Riaz, for presenting your paper. Now, Dr. Ayaman Qazi will present a live session and her paper on the effect of varying thickness of adipose tissues on the ability of neuromuscular electrical stimulation to aid recovery from exercise-induced muscle damage. I will allow her to please present and share her screen so that we all can see Dr. Ayaman Qazi.
Sharing my screen. Sir, is it visible to everyone?
Yes, Dr. Ayaman, we can see. Please
May I
proceed.
start then? Assalamu alaikum and good morning. My name is Ayaman Qazi, and today I'd like to discuss a topic that I looked into while I was in the UK, in which I looked at the effect of varying thickness of adipose tissue on the ability of neuromuscular electrical stimulation to aid recovery from exercise-induced muscle damage. So before we begin, I'd like to give you a bit of a background and purpose of my study. Competitive sports induce fatigue during the intensive exercise bouts. Therefore, exercise is essential to allow for a competitive advantage of the athletes over their competitors. The duration of recovery depends on factors such as training status of the athlete or the level of or the type of activity performed. There's three different types of recovery. First type being recovery training. This is the period allowed for recovery between successive sessions. The second type being short-term recovery. This is the period of recovery between bouts of exercise. The third type of recovery being immediate. This is the recovery between muscle movements or contractions. Performance can be affected if there is inadequate recovery, especially in training. In short-term recovery, which can lead to an increase in the risk of injury. Due to the importance of recovery, making the difference between winning and losing, there's been a vast development of modalities aimed to enhance the process of recovery in athletes. Neuromuscular electrical stimulation being one of them. NMES has been considered a modality for post-exercise recovery, but when using NMES, the type of recovery sought determines the type of NMES to be used. Motor threshold NMES is used when the aim is to induce physical contractions, which increases blood flow to the muscles and therefore increases metabolic removal. Whereas if the aim is to reduce pain, the muscles by blocking transmission of nociceptive fibers, a sensory level of NMES is used. Post-exercise fatigue can either be acute or chronic. Acute effects are brought about during high-intensity exercise, which induce short-term impairments that result in metabolic disturbances. The aim of my study was to determine the various effects, the varying thickness of adipose tissue on the ability of NMES to aid recovery from exercise-induced muscle damage. starting with the methods, a total of 24 recreational active men were recruited from the St. Mary's University campus. And their mean age was of 29 years. Their mean stature was 175.77 meters. Their mean body mass was 73.8 kg, and the mean skin flow was 16.3 millimeters. Except on arrival to the lab, subjects were given an information sheet. They're asked to fill out a consent form and a physical active readiness questionnaire. Participants were asked to visit the lab on a total of 3 different days. The first day being the anthropometric measures and baseline measures. When we speak of anthropometric measures, this consists of height, body mass, and skin fold measures. The skin fold site was marked at the midpoint between the greater trochanter and the tibial landmark. The deposition was placed between the index finger and the thumb to measure skin fold using a calendar. Following the anthropometric measures, baseline measures of performance were then taken, starting with counter movement jumps. Subjects performed 3 counter movement jumps on a jump mat, while holding a squatting position before jumping as high as they can. The average height was then recorded. After a short rest, maximal voluntary isometric contractions was recorded using a strain gauge. MVIC was measured 3 times for a hold of 3 seconds. That means contracting their leg for 3 seconds, 3 times, and then the average measure was then again recorded. The last measure that was taken was to determine delayed onset muscle soreness, that was used using a visual analog scale. Participants were asked to squat at 90 degrees, then indicate the level of soreness in their legs on the visual analog scale that was of 200 millimeters, 0 indicating no pain, and 200 millimeters indicating extreme pain. After these baseline measures were completed, subjects then performed the muscle damaging protocol, which consisted of 100 drop jumps. Subjects were asked to step on a box that was 60 centimeters before stepping off the box onto the ground and jumping upwards maximally after having contact with the floor. They performed 100 drop jumps, that is 5 sets of 20 after each set. 1 minute rest was given to each participant. Immediately post muscle damaging protocol, subjects re-performed baseline measures for commencement of the intervention. Intervention consisted of neuromuscular electrical stimulation for 20 minutes at 4 Hertz. Electrodes were placed on the distal vastus medialis and proximal vastus medialis muscle. Again, the second and third day, visits to the lab were consisted of remeasure of the performance measures that we just talked about, and these were conducted 24 hours and 48 hours post-muscle damage. Now to the important part, the results. The overall rate of recovery increased the greatest for maximum voluntary isometric contraction by 9.5%, whereas for delayed onset muscle soreness, it only increased by 1.6%. Counter movement jump showed an overall decrease in recovery by 2%. And if we look at rate of recovery for counter movement jumps, we can see that initially it was at 92.7. After 24 hours after the exercising damaging protocol, it decreased, and then 48 hours it showed an increase, but still below the baseline value, indicating that there was to some extent recovery after counter movement jumps. Then for MVIC, the initial value was 80.1, and 24 hours later, the recovery did increase, but then if we look at 48 hours later, it increased furthermore than baseline, which is also good. And for delayed onset muscle soreness, we started with 43.8%, and 24 hours later, we ended up at 57.9%, again an increase, but then 48 hours later, we can see that there was a decrease in recovery, indicating that delayed onset muscle soreness did not show an increase. The results showed overall positive and small correlation between skin fold and rate of recovery of counter movement jumps, maximum voluntary isometric contraction, and delayed onset muscle soreness, with the exception of recovery of counter movement jumps at 48 hours and delayed onset muscle soreness at 24 hours, which show a negative and small correlation. If we look here at the table, counter movement jump at 24, it's minus 0.011, whereas for delayed onset muscle soreness at 24 hours, it's also minus 0.147. There's no significant difference between the rate of recovery or any of the performance tests and skin folds. To conclude, the study did not show any effect of various thickness of adipose tissues on the ability of NMES to aid recovery from exercise-induced muscle damage. However, it showed that NMES is an effective tool for recovery. It allows, as we saw on the table, it allows for an increase in recovery after 24 and 48 hours. But it did not show any effect on different thicknesses of adipose tissues. Although thickness layers of adipose tissue require higher currents to induce muscle contractions, our study showed that 4 hours is sufficient to induce visible muscle contractions. Further research is required to determine the exact current which is beneficial in inducing muscle contractions for all thickness of adipose tissues. That brings me to the end of my presentation. Thank you so much for listening.
Thank you very much, Dr. Ayaman Qazi, for presenting your paper.
So 1 second, let me just stop my screen.
Sure. Now, Dr. Fatima Iftikhar will present effects of weighted rope jump training on physical fitness in Taekwondo athletes. It's a recorded session. Let me share the screen.
Assalamu alaikum. My name is Fatima Iftikhar and the topic of my study is effects of weighted rope jump training on physical fitness in Taekwondo athletes. Introduction. Taekwondo means fight with foot and fist is a well-known traditional form of martial art oriented in Korea. Basic skills involve are stances, blocks, strikes, kicks, forms, and breaking techniques. Strength, agility, speed, flexibility, and cardiorespiratory endurance are the main components of physical fitness required for Taekwondo athlete for better performance during fight. Weighted rope jumping training gains importance in terms of improving athletic performance and physical fitness. Objectives. Objective of my study was to determine the effects of weighted rope jumping protocol on strength of both upper and lower extremity in Taekwondo athletes, to determine the effects of weighted rope jump training on flexibility and speed in Taekwondo athletes, to determine the effects of weighted rope jump training protocol on cardiorespiratory endurance in Taekwondo athletes, and to compare the effects of weighted rope jumping training with routine Taekwondo training program on physical fitness in Taekwondo athletes. Literature review. Ipagoglu et al. In 2018 conducted a study to assess the effects of neuromuscular weighted rope jumping training on lower extremity reaction time in Taekwondo athletes. Pre and post assessment was done by Optogen system and the result indicated that the weighted rope training program is effective in decreasing the reaction time. Koleguglu et al. In 2017 investigated the effect of simple rope skipping and the weighted rope jumping exercise protocol on strength performance of young women volleyball athletes. Results showed significant improvement in strength and endurance of both upper and lower limb in weighted rope training group. Methodology. It was a randomized controlled trial. Non-probability convenience sampling technique was used. The sample size was calculated from open aptitude and total 52 participants were selected. Duration of the study was 6 months. Data collection tools were weighted rope with weight 695 gram. Camera digital hand grip dynamometer was used. And data was collected from Hobab Taekwondo Academy, Haripur, Pakistan. Data was analyzed through SPSS variant 21. Inclusion criteria and exclusion criteria. Males with age 13 to 19 years were included. Males having experience of minimum 1 year was included. Already following Taekwondo training program was included. Bantam to light middleweight categories were included. Exclusion criteria. Males with age more than 19 years old were excluded. Those having musculoskeletal injuries in last 3 months were excluded, and those taking anti-inflammatory medication in past 2 weeks were excluded. Randomization. Total 52 participants were divided into 2 groups. Experimental and the control group. Experimental group had to follow weighted rope jump training. Duration was 8 weeks, 3 days per week, repeat method, duration of break 1:1, one set of 10 different rope activities plus routine taekwondo training. Control group had to follow routine taekwondo training only. Duration was 8 weeks and 3 days per week. Analysis. Assessment of both experimental and control group was done at baseline 4th week and 8th week. Hand grip dynamometer was used to assess the hand grip strength and the forearm muscle strength. Agility t-test was used to check the directional changes in athletes. 50-meter sprint test was used to check the speed and acceleration in athletes. Sergeant jump test was used to assess the lower limb strength in athletes. Sit and reach test was used to assess the flexibility of low back and hamstring muscles, and yo-yo endurance test was used to assess the cardiorespiratory endurance in athletes. Results. Bar charts showing mean and standard deviation in experimental and control group at baseline, 4th week and 8th week. This is the first graph showing right hand strength of experimental and control group. On x-axis there are weeks for assessment, and on y-axis there is strength in kg. Second graph is showing the left hand strength of both experimental and control group, and the results shows that significant increase in hand grip strength that was improved clinically in both groups when compared from baseline to 8th week. Now this next graph is showing the agility. Significant changes were found in agility of experimental group, showing p-value less than 0.05. Second graph is showing the speed of experimental and the control group, and the results shows that the speed was improved in experimental group as compared to control group when results were compared from baseline to 4th week and 4th week to 8th week. And the third graph is showing the lower limb strength of Taekwondo athletes. The results showed significant changes in lower limb strength of experimental group, showing p-value less than 0.05. The second graph is showing the flexibility of Taekwondo athletes of both experimental and control group. Significant improvement was seen in experimental group when results were compared with control group from baseline to 4th week and 4th week to 8th week. And the last graph is showing the cardiorespiratory endurance. Cardiorespiratory endurance of experimental group was improved positively, showing p-value less than 0.05. Discussion. A previous study was conducted in 2017 to investigate the effect of weighted rope jumping exercise program on body composition and motor skills in female adolescent volleyball players. There was significant increase in vertical jump test values and a hand grip strength of weighted rope jumping groups. Similarly, the current study shows significant increase in hand grip strength that was improved clinically in both groups when compared from baseline to 8th week. Values of sergeant jump test was also improved in experimental group. Another study was done by Sardar Oren in 2013 with aim to examine the effects of weighted rope jump training by repetition method on the heart rate, anaerobic power, agility, and reaction time of basketball players. And the results indicated that weighted rope training has influenced the heart rate and anaerobic characteristic positively. And the current study also shows significant increase of weighted rope training for improving cardiorespiratory endurance. Another study was done in 2016 in order to know that either the normal rope jumping is better than weighted rope jumping or not in improving physical fitness in volleyball athletes, and the results showed more improvement of agility in weighted rope training group. Similarly, in the current study, significant changes of agility were found in experimental group when results were compared from baseline to 8th week. Conclusion. So it is concluded that weighted rope jump training shows better results than the routine Taekwondo training in improving flexibility, speed, agility, upper and lower limb strength, and cardiorespiratory endurance in Taekwondo athletes. Recommendations. Data should be collected from Taekwondo athletes all over the Pakistan. Further studies should be conducted to check the effects of weighted drop jump training on physical fitness in Taekwondo athletes in different age groups and both genders. Effects on athletes' weight should be added as an outcome measure. These are the references that were used in my study. Thank you.
Thank you very much, Dr. Fatma, for presenting your paper. Now, Dr. Seher Fatma will present her paper, and it's a live session on correlation between disordered eating behavior and anxiety among young female marathon runners. Dr. Seher Fatma,
Yes, sir.
you can share your screen and present.
Bismillahirrahmanirrahim. Assalamu alaikum. My name is Dr. Sahar Fatima. I am from Faculty of University of Lahore. Today I am here to present on correlation between disordered eating behavior and anxiety among young female marathon runners. This is a cross-sectional study. Firstly, I will talk a little bit about eating disorders and how they correlate with anxiety levels in young female marathon runners. So, eating disorders are classified as anorexia nervosa, bulimia nervosa, and binge eating disorder. Anorexia nervosa is characterized as a person with abnormally low body weight, an intense fear of gaining weight, and a distorted perception of weight. If I talk about bulimia nervosa, it is potentially a life-threatening eating disorder. People with bulimia may secretly binge and eat large amounts of food with the loss of control over the eating and then purge, trying to get rid of the extra calories in an unhealthy way, and same is the case goes with binge eating disorders. According to a previous study, evidence related to prevalence of eating disorders in athletic population is limited. Prevalence rate is as low as 1% and as high as 39.2% have been reported in literature. In literature review, in 2016, a study was organized by Smink FR et al. In this study, the author discussed about occurrence of eating disorder has changed over time, and the study concludes that incidence of bulimia nervosa decreased significantly over the past 3 decades, while the overall incidence rate of anorexia nervosa remained stable. Another study conducted by Steen OF et al. In 2013, the purpose of this study was to investigate the prevalence of disordered eating patterns in Hispanic population, and this study concludes that diet self-efficacy emerged as an important construct to consider in developing eating disorder prevention and treatment models. Now, if I talk about the rationale of this current study, previous literature on eating disorder have described that persons with anorexia nervosa, bulimia nervosa, and binge eating disorders are likely to have anxiety symptoms. However, no study is conducted to find the correlation between disordered eating behavior and anxiety in young female marathon runners, and to compare the straight trait anxiety levels of the runners with or without disordered eating behaviors. Objective of the study is to find correlation between disordered eating behavior and anxiety among young female marathon runners. In method section, as I said before, study type was a cross-sectional study, and the data gathered from the University of Lahore and Lahore College for Women University. Study duration was 3 months with sample size 71. The assessment tools were straight trait anxiety inventory questionnaire and eating attitude test questionnaire. Non-probability convenient sampling technique was used. Data was analyzed by SPSS version 23. Young female marathon runners with age 15 to 25 years were included in the study, and the individuals with disc herniation, ankylosing spondylitis, rheumatoid arthritis were excluded from the study. Results indicated that out of total 71 participants, 67 runners had raised anxiety levels, while 3 runners had no anxiety. Moreover, in 56 runners, cause of anxiety was eating disorders, and 15 participants had no eating disorder. Value of Fisher test was 0.028. Correlation was found by Pearson correlation test, and strong positive correlation 0.7 between eating disorder and anxiety scores was found. P-value was significant at alpha 0.003. These are the tables in the results section. In discussion section, previous researches on frequency of eating disorders and anxiety levels in female athletes has revealed a significant degree of anxiety associated with disordered eating. Females who showed no signs of anorexia and bulimia nervosa had the lowest stress and anxiety levels. The present study also supports prior research findings, indicating that there is a significant link between disordered eating behaviors and anxiety levels. There is often despair and distress as a result of the desire to do well in sports activities. Certain sports need a low body fat and thin musculature, and those who participate in such activities are more likely to develop eating problems. Dancers and gymnasts, according to the research, have a higher chance of getting psychological disorders. According to current study, the majority of the participants made themselves ill to lose weight, had low self-esteem, body dissatisfaction, and a fear of failure, which led to maladaptive eating patterns. This current study concludes that the main causes of anxiety among young female marathon runners were binge eating and bad eating habits. Moreover, there was strong positive correlation between eating disorders and anxiety scores of participants. In recommendations, there should be a mental assessment and psychological counseling because they are very important to boost up the confidence and self-esteem of runners, and also because of stress factors and depression, quality of life among runners were also compromised. So this should also properly address in future studies. Now I'm going to wind up my presentation with limitations faced during the study. Major limitations in the study was lack of time and lack of resources. So there is an extreme need to hold future studies with proper funding and time. There was also no follow-up for the study. So this is the end of my presentation. These are the references. Thank you, everyone.
Thank you very much, Dr. Seher Fatma, for presenting your paper.
Thank you, sir.
Now, our next participant, Dr. Arufa Jafar, will present on effects of core stabilization training program on core endurance and dynamic balance in young martial arts students, a randomized controlled trial. It's a recorded session. Let me share the screen.
Hello and welcome to the third International E-Conference on Rehabilitation Sciences. Good morning, ladies and gentlemen. Let me introduce myself quickly. I'm Arufa Jafar, a sports physiotherapist, a researcher, and a clinical practitioner. Thank you for coming today. I'm looking forward to talking with you about the importance of core stability and the role it plays in training of specific sports. Let's start by looking at the topic of our research that mainly explores the effects of core stability training on dynamic balance and core muscle endurance in young martial arts students. It was a randomized controlled trial. To begin, I'd like to share with you the key points of today's talk. My talk this morning is divided into five main sections. First of all, the introduction and background of this topic. Second, rational objectives of our study. Third, the materials and methodology used for this study. And finally, the results and conclusion for today's presentation. Let's start by looking at the introduction and background. Do you know that many novice practitioners don't realize the need to strengthen their abdominals? Perhaps they are too busy in learning the basics of martial arts like kicking, striking, and poking. One reason for this lack of attention is that we don't really use the abdominal muscles on a day to day basis. But strengthening the core muscle can improve on stability as well as the balance. For instance, you need to have a very good balance in Taekwondo, as most of the kicks involving having one foot off the ground. Also, core muscles like obliques add power to the punches and kicks. Have you ever heard that a punch begins with a push from the left, with a force moving through the body, shoulders, arms, and then to the fist? Now, if you have a weak core, the punch loses some of the force that the legs generated. On the other hand, if the obliques are strong, it would add to the power of the punch. Another reason why we should aim to have strong core is that it can protect your organs from damage, especially the abdominal muscles. Now, I'll share with you why this study was needed and why this study was conducted. As core stability and strength is much essential in good techniques in all of the martial arts, this research was conducted because we were interested in finding out how this important connection can be verified in a controlled research setting. Only one English article was found, including martial arts and the core. It has not been studied much in any settings. We did expect to find more than one study that fulfilled the criteria. Why is it that more interest has not been shown? Maybe published articles are not in English. Maybe experimental controlled studies on this particular subject are not so popular. Or maybe this aspect of martial arts is not studied for some reasons. These were all the queries that led to the concept, formulation, and execution of this experimental controlled trial. So, this leads to our research question stating, is there any significant effect of core stability training program on core endurance and dynamic balance in young martial arts students? Now, let's have a look at the significance and impact of this study. Many physical therapists with a sports community background and the athletic trainers can get an insight to form better training regime depending upon sport specific demands regarding the postural control and dynamic balance for the martial arts practitioners. Also, it can provide a better understanding of basic concepts of core stability to be executed into the training of the martial arts. Moving on to the next point, I'd like to briefly explain what literature says about this study topic. In 2015, a study was conducted on 10 karate practitioners and observed that martial arts practitioners need a great deal of dynamic balance. This can be achieved with strong and flexible lower extremity muscles working in coordination with the strong core musculature. Another study in 2012 was performed on healthy individuals. It explained that muscle endurance is much more important component than muscle strength, as poor endurance of hip and trunk muscles is a major risk factor for injury to the spine. Another randomized controlled trial was performed on badminton players in 2016. They performed 6-week core strengthening exercises. Training results showed significant improvement in core endurance and dynamic balance. In this way, literature supports the evidence regarding the positive relationship between core stabilization training program and improvement in core endurance and dynamic balance. Now I'll move on to the next point, which is materials and methodology for the study. It was a test-retest randomized controlled trial with a total duration of 4 months. Subjects with the age of 15 to 20 who were actively engaged in martial arts practice were included in the study. Any participants who were taking medications that can affect the balance or with the neurological or orthopedic disorders were not included in the study. As for data collection tools, 4 types of functional tests were used to assess any change in core endurance and dynamic balance. Abdominal fatigue test, back extension test, and side bridge test were used for the assessment of core endurance, while star excursion balance test was used for the assessment of dynamic balance. Now let's discuss how the data was collected. In total, 40 subjects were evaluated for eligibility, from which 30 were selected as sample. By using lottery method randomization, subjects were allocated to the experimental and the control groups. Each group underwent the pre-testing phase by using 4 functional tests described earlier. Experimental group participated in a 3 week core stabilization training program with a total of 12 sessions, along with the regular martial arts classes, and the control group didn't perform the core stabilization training program. They only participated in the regular martial arts classes. Post-test readings were noted after the follow-up completion. Now, let's take a look at the exercise plan. It was designed taking into consideration the latest evidence available. It was a 3 weeks plan with the 4 sessions per week. Entire practice regime comprised of basic, intermediate, and advanced levels, total of 3 levels. Now, let's move on to the results sections. As you may remember, I shared that for the assessment of core endurance, we utilized abdominal fatigue test, back extension test, and side bridge test. As you can see here, this graph illustrates that in the post-exercise testing phase, treatment group for each test revealed statistically significant improvement in the core endurance. Similarly, for the dynamic balance, we used star excursion balance test for 3 directions: posterior-medial, medial, and anterior-medial directions. Each direction indicated significant improvement in the dynamic balance in the left and the right lower extremities. Like here, this graph is for the left lower extremity and this one is for the right lower extremity. Like each study have its own restrictions and limitations. Major restraints for this study were the shortage of time, difficulty to find young female martial arts practitioners, and most importantly, limited literature evidence available. So, for the future researchers, I would like to recommend the comparison of 3 weeks course preparation training program with the 6 weeks course preparation training program, as 6 weeks program have more evidence available in the literature. Upcoming research should also focus on integrating the course preparation training into the martial arts specific techniques for the competitions. As the primary goal of this study was to find out statistically significant effects of core stabilization training on the core endurance and dynamic balance, and it was clearly evidenced by the difference between experimental and the control group results. And on this final note, it concludes the focus of discussion today. If anyone who like more information or have any questions, please feel free to contact me at the given email. Thank you so much for your interest and attention.
Thank you very much, Dr. Rufa Jaffer, for your presentation. Now, again, I would like to call Dr. Ayaman Qazi to present her next paper on effect of seated and standing cold water immersion on recovery from exercise-induced muscle damage. Dr. Ayaman, please proceed and share the screen.
Assalamu alaikum. Good morning. Thank you for giving me the honor to be able to present 2 of my papers today. This study I conducted again while I was in the UK, and the study was the main study that I conducted for my MSc thesis. So I gave a lot of hard work and dedication into this, especially when I had to do it during the COVID times. So So the topic of my study is the effect of seated and standing cold water immersion on recovery from exercise-induced muscle damage. Before we start, I'd like to give you a small background and purpose of my study. So first of all, the first question that comes into mind is, what is exercise-induced muscle damage? Basically, it's unaccustomed exercise that results in a cascade of events in the muscles. These different events include impaired muscle force producing capacity, delayed onset muscle soreness, otherwise known as DOMS, increase in specific intramuscular proteins in circulation, swelling of the affected limb, decrease in range of motion, and ultrastructural muscular disruption. Another question that arises is, what causes exercise-induced muscle damage? We know that there are three different types of contractions. An eccentric contraction is when the length of the muscle increases. So the greatest damage is caused by eccentric contractions. And different modes of exercises result in these symptoms. And these different modes include resistance training, prolonged running, downhill running, and intermittent high intensity exercise. Some of the physiological effects of cold water immersion include there's a temperature dependent changes that occur in the body, and there's an analgesic effect. There's a decrease in tissue metabolism and blood flow, which causes an overall reduction in muscle soreness, edema, and faster recovery. Some of the physiological effects of hydrostatic pressure include it causes the displacement of fluids from the extremities towards the central cavity. Displacement causes translocation of substrate from the muscle, increase in cardiac output, reduced peripheral resistance, and increased ability to transport substrate. This results in an overall reduced perception of fatigue and aids energy conservation. The aim and objective of my study was to compare the effectiveness of different hydrostatic pressures on recovery from exercise-induced muscle damage. A question that might arise in your mind is, how would you attain these different hydrostatic pressures? That was attained by having the participants either seated or standing in water, and they would be submerged in water up to their superior iliac spine. Whether they'd be seated, it'd be up to their superior iliac spine, or whether they'd be standing, it'd be up to their superior iliac spine. That would create a difference in hydrostatic pressure. So onto the methods. A total of 30 participants were recruited for the study, of which 29 were male and 9 were female. To allow for an equal distribution of participants in these three groups of seated standing cold water immersion, standing cold water immersion, and control group, they were distributed by their gender, having three females and 7 males in each group, and by their body mass. If we look at this table, you can see that the average body mass for each group was quite similar, not highly off by a lot of points. On arrival, subjects were given an information sheet. They're asked to fill out consent form and physical activity readiness questionnaire. This study also consisted of 4 visits to the lab. The first visit being the familiarization session, which the participants came to the lab. They were familiarized with the muscle damaging protocol, the functional performance test, and an anthropometric assessment was performed. 1 week after the familiarization session, participants were called back to the lab for their experimental day. And this is the day in which they actually conducted the performance test and blood markers. The blood markers consisted of taking a measure of serum creatine kinase, in which a lancer was used to pierce the air and blood was filled into a capillary tube. And for the performance test, counter movement jump was performed on jump mat, having the participant squat down and then jump as high as they could. This was performed 3 times. The average reading was taken. Maximum voluntary isometric contraction was taken using a strain gauge, in which the participant was seated and they're asked to hold a isometric contraction of their quadricep muscle for at least 3 seconds. And this was performed 3 times, and the average reading was taken. 30-meter sprint time was recorded using an infrared laser light, in which the participants were asked to stand behind the light to avoid accidental trigger, and they were asked to run for 30 meters, and the average time was recorded, and they were asked to perform this 3 times. Again, average time was recorded and then used for further analysis. Delayed onset muscle soreness was taken using a visual analog scale, which was a scale of 200 millimeters, 0 indicating no pain, 200 millimeters indicating extremely painful. After these measures were taken, the participants then moved to the muscle damaging protocol first, which included a 20 times 20 meter sprint with 5 meters deceleration zones, in which participants were asked to run 20 meters one way and 20 meters back, after which they then, after a few minutes rest, then moved towards the drop jumps, in which they had to jump from a 60 centimeter box. When they jumped off the box and onto the ground, they were then asked to jump again. This was conducted 100 times with 5 sets of 20. Between each set, there was a 60-second rest. After the muscle damaging protocol, the participants were divided into their respective interventional group, which consisted of standing cold water immersion, seated cold water immersion, and control. For the standing and seated cold water immersion, the participants in these groups were either seated or standed for 14 minutes in 14 degrees Celsius water with a difference of hydrostatic pressure. For the standing cold water immersion, it was at 830 millimeters of mercury, whereas for the seated cold water immersion, it was 780 millimeters of mercury. For the control group, this consisted of a sham ultrasound for 14 minutes to prevent any placebo effect. So the third and fourth visit was again a remeasurement of the blood markers and performance test, which was again conducted 24 and 48 hours after the exercise-induced muscle damage. So a quick recap of the overall process was the first, on first visit, which was experimental day, participants came, had their blood measures and performance tests taken, after which they performed the muscle damaging protocol. If we look here, exercise-induced muscle damaging protocol, which consists of drop jumps and the 20 times 20 meter sprint. Like 1 hour post that muscle damaging protocol, again, measures were taken, after which they're allocated into their respective interventional groups. After their intervention, they're allowed to go home. They're asked to return 24 hours later. Again, measurements were taken, and then again 48 hours later, in which measurements were taken. In these 24 and 48 hours, only measurements were taken. The intervention was not performed again. Now, if we look at the results, there's a significant effect of time on delayed onset muscle soreness, on counter movement jumps, with all of these indicating a p-value of less than 0.01 for MVIC, 30 meter sprint, and serum creatine kinase, but there's no significant group in time interaction, for a p-value for DOMS being 0.120, p-value for CMJ being 0.134, for MVIC p-value being 0.254, and for 30 meter sprint p-value being 0.113. No significant difference between seated or standing cold water immersion. There was no significant difference at 48 hours post-exercise-induced muscle damage with small effect size. If we look at the effect size of DOMS, effect size was 0.25 for DOMS. For counter movement jumps, it was 0.39. For MVIC, it was 0.23. 30 meter sprints, it was 0.22. And the greatest effect size, if we see, it was for serum creatine kinase, which was 0.63. If we look at MVIC, we can see that over time there's a decrease in the isometric contraction, the strength of it, with the lowest being at 24 hours for all three groups, with a gradual increase 48 hours later. There's no interaction between groups in time or difference between groups. At 24 hours, the effect size was 0.23, and 48 hours, the effect size was also 0.23. Post-exercise induced muscle damage, there was no significant difference between either the hydrostatic pressure groups of seated and standing cold water immersion. For serum creatine kinase, there was an increase with time, reaching its highest almost 24 hours post-exercise-induced muscle damage. There's no significant group into time interaction. There's a large effect size between sitting cold water immersion and control at 24 hours, with effect size of 1.17, p-value 0.044. We can see here, and no significant difference between sitting and seating cold water immersion at 48 hours, a p-value of less than 0.05 and effect size of 0.63. So to conclude, modifying the hydrostatic pressure of water by having participants use a seated or standing cold water immersion protocol was no more effective in accelerating or reducing indices of exercise-induced muscle damage in the control group. These findings are supported by Leader et al., in which they also looked at the effects of seating and standing cold water immersion, but their intervention was different. And they only consisted of different sprints with no drop jumps. Cold water immersion has a small but significant effect on reducing the efflux of creatine kinase after exercise. Based on the data from this investigation, seating and standing cold water immersion does not improve recovery after exercise-induced muscle damage, therefore questioning overall the use of this intervention in practical settings. Thank you so much for your time.
Thank you very much, Dr. Ayaman Qazi. Now we have our second last presenter, Dr. Aisha Razak. She will present on effects of dose response of Nordic hamstring exercise on muscle performance in athletes, and it's a recorded session.
Bismillahirrahmanirrahim. Myself, Dr. Aisha Razak, is going to present in the International Conference of Rehabilitation Sciences, the oral presentation on the topic Effect of Dose Response of Nordic Hamstring Exercise on Muscle Performance in Athletes, and my co-author is Dr. Saidullah. Hamstring injury is the second most prevalent musculoskeletal injury in different types of sports. 60 to 80% hamstring injuries happen in the layered swing phase. It is the position where the muscle works eccentrically. In 2001, an effective eccentric muscle strength training program based on the Nordic hamstring exercise was developed. This program includes high volume with 700 Nordic hamstring exercise across a period of 10 weeks. This high volume induces the DOMS, and this probably is the reason why this 10-week exercise program has presented low compliance rate of about 16.7%. About this exercise, after warm-up, the participant or the athlete kneel on the ground with the upper body straight, and the spotter and the other person, the spotter, secures the ankle. The participant has to lean forward, has to come low as much as he can, avoiding the fall. In this whole process, the person uses the hamstring as the brakes in his eccentric range to prevent the fall. If the person feels the fear that he can fall, he can use his hands and then touches the chest to the ground and then returns back to the original kneel position. According to at least half a dozen recent studies, almost 2/3 of the hamstring injuries might be prevented by increasing the hamstring eccentric strength. Just like in this study, it shows that there is 70% reduction in the participants' injuries after the Nordic hamstring exercise program, and 85% less injuries reported in those players who were previously being suffered by the hamstring injuries. A systematic review and meta-analysis on the 15 study with 8,459 athletes shows that there is overall, on average, there is 51% reduction in the hamstring injuries. Performing 6 sets of 5 repetitions of the exercise per week, the strength of the hamstring was incredibly increased. Comparing two groups of Nordic hamstring exercise dosage, one with 3 repetitions, 3 sets, and other with 6 repetitions with 3 sets per week, showed that both groups treated showed improvement in terms of strength and motor neuron activation. There are a lot of studies that are being working on different dosages of the Nordic hamstring exercises. Even in the face of promising Nordic hamstring exercise preventive effects showed by the previous studies, adoption and the compliance of the Nordic hamstring program is still very low. Evidence suggests that lowest dose of the energy required to enhance athletes' performance is yet to be found, and that is the research gap for this study. The study is clinically trial registered at the National Library of Medicine, also got the ethical letter from the Riphah Ethical Committee. It was an RCT done between the July 2020 to January 2021 at the JKT Cricket Academy and the Sports Center Peshawar. It The data was collected by the non-probability convenience sampling technique, and it was 34 that is being collected by the OpenEpi tool by using the mean and the standard deviation of the muscle strength of the parent study. So we put 17 participants in each group by using the sealed envelope method. Objectives of the study are to determine the effects of Nordic hamstring exercise dose response on hamstring muscle size and strength, to determine the effects of Nordic hamstring exercise dose response on speed of the athlete, and to determine the effects of Nordic hamstring exercise dose response on agility of the athlete. Inclusion criteria: we included athletes of both gender that are being participated for at least in different sports for at least 6 months and were in the ranges 18 to 30 years. The subjects were included after they have given the written informed consent. The subjects were excluded if they have any of the knee or ankle ruptured or torn ligaments, if they have spine or knee and hip injury or the surgery, or if they have knee instability. The tools were the single leg hamstring bridge test, in which this is the position of that test, in which the person have to adapt this position to check the strength of the hamstring, and this is quite a reliable test, and a lot of studies are being done on the reliability and validity of this test for the hamstring strength. Agility test. This is the test for the agility. 30-meter speed test for speed, and anthropometric measurements to measure the size of the hamstring muscle at 3 levels: 5 centimeter above patella, 10 centimeter above patella, and 15 centimeter above patella. Treatment protocol for group A, that is the higher volume Nordic hamstring exercise group, we performed 3 sets of 3 repetition 3 times a week for 4 weeks, and for group B, that is a low volume Nordic hamstring exercise group, we performed 3 sets of 3 repetition 1 time a week for 4 weeks. Both the groups were measured pre and at 2 weeks and at 4 weeks of treatment. This is the console diagram that shows initially we took the 40 athletes and 6 were excluded. Among those, 4 were not willing to participate and 2 withdraw during the training. And then the remaining 34 were randomized into 2 groups, 17 in each group. We perform our training program to this high and low dose NHE program, and then we perform the outcome measures, all the 4 outcome measures, and the result was measured at the level of baseline, 2nd and the 4th week. Data analysis was done on the SPSS version 21, and normality was checked by this Shapiro-Wilk test that shows that most of the values are less than 0.05. That means that the data was not normally distributed. So we apply the Mann-Whitney U test for between the group analysis and Friedman test for within the group analysis. The results shows that the age of both the groups was about 23.71 plus minus 3.601 and 23.12 and plus minus 3.82. BMI was 21.69 plus minus 1.9 for group A and 20.46 plus minus 1.86 for group B. Experience was 50.47 plus minus 46.3 for group A and 28.59 plus minus 20.37 for group B. And there were 13 males and 4 females in group A, and all the 17 males were included in group B. The BMI shows that most of the athletes lie in the range of the normal and the underweight category. Within the group analysis shows that both the treatment groups, the group A, that is the higher volume Nordic hamstring exercise group, and the group B, that is the low volume exercise group, both show the significant improvement after the 4 weeks, and the results were even significant even after the 2nd week. And these things are being obvious from the previous studies also. When we apply the between group analysis, that is the Mann-Whitney U test, it shows that the yellow bar, that is of the higher volume Nordic hamstring exercise group, and that is a group A, shows that the agility of the person improved significantly after the 4 weeks as compared to the group B. and that the person becomes more active and more agile after the treatment. The speed of the person that is being measured by the 30-meter speed test also shows that the group A, that is a higher volume Nordic hamstring size group, covers the distance in lesser time after the 4 weeks training as compared to the corresponding group B, that is a lower volume group. Hamstring strength, as is shown in this graph, although the group A was initially at the lower level in strength than the group B, even then it goes significantly beyond the group B after training of 4th week. The muscle size measurement that was being taken by the anthropometric tape at the level of 5 centimeter above patella, 10 centimeter and 15 centimeter above patella shows that at all the 3 levels, the yellow bar, the higher volume bar is much greater than the group B, that is a low volume dose. So in the group A, there is more muscle size increased more as compared to group B. Discussion. Studies shows that the training program with the lower doses such as 2 to 3 weeks for hamstring muscle did not provide clear evidence of improving the strength, but the studies show that the strict compliance of NHU program for at least 4 weeks showed significant improvement in reduction of hamstring size rate. So current study also shows that the low dose at the 4 weeks gives the increased strength in the hamstring. According to another study by the Guri et al., it shows that there was no significant effect of low dose of energy training program on reduction of hamstring, but higher compliance and higher doses such as 6 to 8 weeks of training have better effects on hamstring injury reduction program. The current study also shows that the higher volume and the higher compliance that is being observed by the low doses provides the increased strength in the hamstring muscles. Conclusion, both higher and low doses were effective in improving the hamstring strength, size, speed, and agility, but the higher dose of energy was more effective than the lower dose after the 4 weeks of training in improvement in strength and size of hamstring as compared to speed. COVID-19 pandemic standard operating procedures restrained many athletes to underperform. That is a limitation of the study, and the recommendations are that the future studies should be conducted on the effects of dose response of energy on other lower limb muscles. These are the references that are being put by the endnote, and that's it.
Hello and welcome to the third international.
Thank you very much, Dr. Aisha Razak, for your paper presentation. Now we have our last participant, Dr. Shahir. If he is present in this session, then we will proceed with his paper. Or Dr. Rashid will present on his behalf. I am requesting again to Dr. Shahir or Dr. Rashid if they are present in this session. Okay. So with this, we are completing our today's presentations and all the oral presentations, and the forum is open for the question answer session. So if anyone want to ask any question, the presenters are here and the session and the forum is open. Any questions from the participants? Okay. If there are no questions, then I will request the chair, Dr. Keramatullah, to please
ask the question first, if you don't mind.
Okay, sir,
Is it okay to ask question? Is it okay for a chair to ask question?
Now, sir, it's up to you, and I will request Dr. Keramatullah, chair of today's session, to give comments and the summary of today's presentations.
Okay. Thank you very much, Dr. Hashim. I hope I am people are hearing me. I am very thankful to Riphah International University for organizing such a wonderful conference. It gives us the feeling of reality rather than virtuality. And I think I am more focused. Things are just in front of my eyes and sounds are coming directly into my ears. So that's a big achievement. You may call it virtual, but it feels real. I appreciate the effort of the whole team who put a lot of effort behind organizing this conference. And I believe some of the people were awake for 36 hours to make this thing happen. And being a chair of this session, I can see a lot of good work, a lot of effort done by the students during their master's studies or maybe some other higher level studies in the posters, which are so nice and they are very well presented. And of course, when you do a research, there are merits and demerits. There are limitations that comes with almost all the studies. So overall, it's a great work. It is well reviewed, I think, and there are a lot of new aspects and flavor of various sporting injuries in the whole presentation. And I am delighted to see that people have done such an effort and a nice presentation. One of the studies, however, I noted that few of the things could be improved, like we are not very vigilant to differentiate between the terms frequencies, incidences, and prevalences. In my humble opinion, I guess that some study could take the title of prevalence rather than frequency. And in some instances, we could not generalize the finding of the study. So if the study is done in Rawalpindi, it need to be mentioned that that was done in the athletic population of Rawalpindi and cannot be generalized to the people of the northern areas who don't have much of the grounding facilities or level grounds. And in some cases, it was interesting to see that marathon female runner were studied. I'm delighted to know that 71 female, somebody could get that, who could run or who could have participated in 45-kilometer run, and the effects of varying diet when they were taking and the condition like neurobulimia or other conditions, and our graduates were keen to study those populations and reach out and find the percentages and frequencies among those female athletes. I am really very much impressed by one of the studies, or actually two studies, of Ayaman Qazi. And one study was in relation to the effect of the cold water baths and standing and lying on the exercise induced or don't induce, 100 jumps drops, soreness. And it was really interesting to see that recovery in those injured patients occurred after 48 hours. And I was just thinking that that's why in sporting scenarios, 48-hour rule is included. So if somebody does an activity, a hard match or an extensive physical activity, it needs at least 48 hours to recover from it. So it was seen from maximum voluntary contraction, isometric contraction, and level confirmed that those levels are coming to normal, and probably 48 to 78 are rules the first 3 days, which are very important. We could see that if we could we put the athletics under severe condition, if you play a match today and if you put a lot of effort in it, it may need 48 to 72 hours to recover from the micro injuries which happens in the muscles and manifests as delayed onset muscle soreness. So Ayaman Qazi did really well to support those ideas. Maybe there were a little bit of things. I think that the study happened in the UK. In Pakistan, there is usually a concept that if you put some people in a cold water, he may get really ill. This is just a myth. So it is not in practice here, I think. And gradually, our coaches and sports persons could move to that direction to include the cold baths and gentle exercise after a match, or a bit of cycling after a match will help recover from the adverse effects of DOMs and injuries, and will prepare the players for the next event. Aisha Raza did really well to study the effects of those related Nordic hamstring activity exercises, and the study was nice. However, my whole comment will be just a few of the studies would need to be revisited, restructured in terms of presentation. I believe they have done a lot of good work behind it, but probably could not present. So I am so much delighted to see that such nice people are around us, and they can help us in the management of sporting injuries and trainings. Thank you very much.
Thank you very much, Chair Dr. Keramatullah, for your summary for today's presentation session. Now I will request our co-chair, Dr. Muhammad Kashif, to please summarize today's presentation.
Bismillah ar-Rahman ar-Rahim. Dr. Keramatullah already explained the merits and demerits of different studies. And he mentioned that there might be the prevalence in replacement of the frequency. Am I right, Dr. Keramatullah?
Yes, Dr. Kashif, you are right. In some studies, there will be prevalence terms will be more appropriate.
But there is a debate. Some, if you send the paper to some journals, they are saying you need to write the frequency, and some are saying you need to write the prevalence.
This is a common, like, if it is a single team,
I think there is
a specified population, at a specified time and single team, and like if I'm reporting statistics from my hospital, these are incidences, okay? And if it is the specific time rather than generalized, it could be frequency. And if it is very generalized, like injuries, like, some studies needed to, two objectives were there, and one was kind of level of fitness and frequencies. So level of fitness is really does not match with the frequency. And again, if there are football players, cricket players, hockey players, at a sport playing population, but not specifically, because each sport has a different requirement, biomechanical requirements, and the level of injuries, like in overhead athletes, shoulder injury will be common. In fast bowlers, shoulder injury will be common. But if you are playing football, of course, direct injuries will be more common in the lower limb. Okay, so those ankle instabilities, there was a study on the ankle instability. That was very good. It was more specific. It was more kind of frequency. So if it is
therefore,
just, it will be a common thing.
Therefore, I ask you this question. that you are, because you are very familiar with these terms. And regarding the session, it was wonderful. Sports injury, sports rehabilitation, these things should be advanced day by day in Pakistan, as we are not have a lot of studies. So Keramat Bhai, as a chairperson, and as I know him, he has a lot of experience in dealing the patients having sports injury. During this session, we have 10 studies. 5 of them were related to the association and we can say the prevalence, and the 5 of them were RCT studies. As the technical points have been raised and addressed by the Keramatullah, I just want to address some the limitations of these studies or the recommendations. A few of them have regarding the prevalence, or you can say the frequency. All of them or majority of them reported that they have done studies in a specific area. So there is dire need. We need to have a large population like the football players. We have to include the football players of from all Pakistan, from, or we might have the players from one province to generalize the results. Like the first one study is saying they have very good fitness level regarding and the second one was saying that there is a limited, they have mild difficulty in areas. A third study which was addressing the kinesiophobia problems or the frequency in athletes having the chronic ankle instability. I would like to recommend they must have in future address the coping strategy to deal these kinesiophobia things. 5 of them studies were RCT study. It is very wonderful that the peoples are on the track. They are having they are comparing the effects of the different exercises, and but there is also, if we see, there might be, we can add the sample size, effect size, some technical things but the two of the studies did these things very well. Console diagrams, 2 of them or 3 of them follow these things. So I think there is all, if we see generally, all of these studies were very well, and in the perspective of Pakistan, there is dire need. We have to address all these studies, especially in sports, physical therapy, as we are the sports specialist. We have to conduct more studies regarding the mechanisms of the injury. One thing more, we need to address biomechanical aspects of the study. So thank you very much, Hashim. You run an excellent session. I'm very thankful to Keramat for his feedback, especially regarding the frequency and the prevalences.
Thank you very much, Co-Chair Dr. Muhammad Kashif. And once again, in the end, I would like to request our chair, Dr. Keramatullah, to give concluding remarks about today's session.
Thank you very much all for listening patiently, watching patiently, and enjoying this whole session. Listening is very hard, but I think that it is just the start of the wheel. It will move. We will move forward. We will do more studies. We will go to a status where on the international level, where we need to highlight our issues and to solve our issue. We will identify the problems, and then we as a good nations or good citizen or good sports person or good sports physical therapist, we will play a role to find through researches our problems and find the solution to those problems so that we can stand proudly among the nation in the world. So it is just the beginning. I believe Riphah International University is organizing this third international conference. we have invited people from all the specialities over the world to witness what is happening, and we get a bit of guidance from them to move forward, to learn from their experiences and make ourselves better professional, not only in the sports and exercise side, but all the domain of physical therapy. And I believe that our team members here in Pakistan, they are very much committed. We have learned a fair bit of time in a short while of 5-6 years. Unlike the people, like, who are the countries which are very advanced, have advanced facilities, but within our own means, we will do a better job. We will find our problems because they are mostly different from the rest of the world, and we will propose solution to those problems in accordance with our available resources. So thank you very much, all of you. You did a very good job. Thank you very much.
Jazakallah khair, sir. Once again, I've been thankful to all the participants of today's session for presenting these wonderful papers. I am thankful to the chair, Dr. Keramatullah, co-chair, Dr. Muhammad Kashif, for giving us their precious time. Jazakallah khair. Now I'm going to conclude today's session. And inshallah, today we have a lot of plenaries coming in afternoon and after half an hour, and by the end of today we will be having the closing ceremony as well. So you all are requested to please continue today's sessions and the conference. Jazakallah khair. Assalamu alaikum and Allah Hafiz.